So friends, from today, the next three sessions will be looking at the anatomy of the skull base. And today, of course, we are going to discuss on the anterior skull base anatomy. We try and segregate anatomy into compartments, and that's really for simplicity, as you can understand. But anatomy, like physiology, like development, like pathology, doesn't respect just strict boundaries that we try and use to simplify our task. So let's just go to the next slide. Right. So the skull base, especially the anterior skull base, it's quite intricate in terms of its location. It is really a gateway between very important structures in front of our face, i.e. the orbit and the paranasal sinuses, as well as the nasal passages, and it shares a common developmental process with these areas, which we'll have a look in a minute. Um, so the anatomy is very much intertwined with the development of these structures, and hence you will realize infection, tumors, trauma, when it affects one area, can easily involve the other areas which is in the vicinity. So you kind of have realized how I like to share these discussions. We understand that to understand pathology, we need to understand the location of the pathology, the anatomy, and to understand the anatomy, we need to understand how the structure has developed. And hence, we try and go back to embryology to try and see the roots of the evil, if you like, the roots of the disease. But the beauty is it helps us understand the anatomy as well. So now you must be getting bored of this image that I have shown so many times in the past, where we have got a neural tube, and on the neural tube, which is basically uh, the neural plate on the surface, and underneath, as you know, is the endoderm. So you have got the ectoderm on the surface, which is the neuroectoderm, which is what we are seeing. So we are seeing the top of this neural tube, and on this you have got these areas of thickening of the neural tube, ectoderm, and these areas of thickening will later on form the various vital structures. You have got the otic placode, which will be responsible for development of the ear. You have got the visual one, and of course you have got the olfactory one. And what these areas of thickening, these areas of neuroectodermal thickening do is they will be responsible for specific patterning that will occur. They will be responsible for secretion of specific neuropeptides, which will then govern the changes that are going to occur in the superficial ectoderm, in the superficial skin and the developing facial structures. They will influence the development of the pharyngeal arches. And this is what we are seeing here in gross anatomy, if you like. So it is under the influence of these areas of neuroectodermal thickening that we get development of the face that has happened. So for example, the face is developed from uh, 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 the frontal process, which is an overgrowth, which as a reflection of the growing underlying cerebrum. The frontal process then divides into the nasal, medial, and the lateral nasal processes, which we are seeing here. And on either side, we have got of the medial and the lateral nasal processes, you have got the developing olfactory placode and the nasal pit. Uh, and these two on from each side join together to form the nose in the midline. Similarly, we have got the pharyngeal arches, the maxillary and the mandibular, which will come from underneath and surround the developing stomatodium, which is the developing mouth. And this completes really the formation of the anterior face as such. Again, it's very important to realize that this is under the influence of the neural tube, the neural plate, which is basically the underlying brain parenchyma. So the brain really is governing how the face and how the nasal structures are going to be formed. And this is also reflected in later on in pathology, because these are not only influenced, but also they share the common metameres. eye, we know that the visual pathway is diencephalic in derivative. It has a relay within the thalamus. Similarly, the mandibular arch has got a rhombencephalic metamer. So for example, what I'm trying to emphasize here is a fact that if you have got a disease, someone who's got a facial malformation around the mandible or in the eye, it is so vital to ensure that you look intracranially. If it's a orbital AVM, we have to ensure we are looking at the thalamus carefully. If you've got a mandibular jaw AVM, we have to make sure there are no abnormalities within the posterior fossa, within the pons, cerebellum, and these are metabolic syndromes. And it is just a reflection that not only do they share the common embryology in terms of its development, but also pathology-wise, they can have similar associations. As I said, the face, it develops from the nasal, frontonasal process here, and then the maxillary processes which surround the developing eye and the surrounding the developing nose over here, and that gives rise to the face. If you look carefully further down now, if you look at how the eye develops, as I said, the eye, the optic nerve really is a derivative directly of the neural tube. So it is not like a peripheral nervous system; it is part of the central nervous system. And this is the optic vesicle. So this is really a continuation of the of the neural tube, and hence the ectoderm, which is on its surface, which is a neuroectoderm, which is eventually going to form the retina, which is what we are seeing over here. This is the optic vesicle, which then later on is going to form the presumptive neuroretinal cell. And you can see how this optic vesicle is actually going to form a cup-like structure. So this is the optic cup, which is going to then later on going to form the retina itself and the pigmented epithelium. So this choroid and the retina are neuroectodermal derivatives. And what happens, as I was alluding earlier on, is this growing optic vesicle, which is again neuroectodermal in derivative, is going to influence the superficial ectoderm, and that is then subsequently going to invaginate inside to forms the lens vesicle and the lens placard over here. So the lens itself, along with the cornea, are ectodermal in derivatives, whilst the retina and the choroid are neural tube in derivative. So this is kind of a brief overview of the development of the eye. The sinuses, the paranasal sinuses and the nose, they are basically they develop as an outgrowth from these from the nose, from the lateral wall of the nose, and they are very much influenced, of course, under genetic influence, but also environmental influences, depending upon where we live, depending on the altitude, depending upon the oxygen concentration, and hence the various sizes and shapes of the nose and the face across the globe. The other important fact to realize is that most of the sinuses are usually rudimentary at birth. Though they may be present, but they are very, very rudimentary. And the pneumatization within the bone, i.e. the cavitation that occurs later on, carries on at least for the first decade in the life, and especially in the case of the ethmoid, can carry on up to 12 to 13 years of age. The sphenoid sinus, you'll realize the adult size is not reached till at least 15 years of age. So the sinuses may or may not be seen clearly at birth on radiography, but they will evolve in the first 2 decades in life. So let's look at what are the areas we're going to concentrate on. So this is just the skull base. We are looking over here. You have got the anterior, the middle, and the posterior cranial fossa. We're looking from above. So the definitions of the anterior cranial fossa, of course, it starts from the oops, sorry. Okay, we'll stay here. From the frontal bone here anteriorly, and this area over here is the roof of the orbit. You have to understand the orbits are going to be underneath here. So these are the lateral orbital plates of the frontal bone. And as we reach posteriorly, before we reach into the sphenoid sinus, there is a ridge of bone, which is the lesser wing of sphenoid, which defines the posterior margin of the anterior cranial fossa. So this is kind of the lateral aspect of the anterior cranial fossa. And in the midline lies a very specific area, which is called as a cribriform plate. And we have looked at this earlier on when we talked about the olfaction, the olfactory apparatus. There will be a little bit of revision of that bit later on. And this is the ethmoidal aspect of the anterior cranial fossa. So laterally we have got the frontal bone, but medially we have got the ethmoidal bone. And the ethmoidal bone, the cribriform plate, is responsible for transmission of the olfactory nerves, which pierce that to give that cribriform appearance. So here it is on a zoomed picture, what it looks like. You've got the orbital roof. So this is a lateral plate of the frontal bone, and in the midline over here, you have got the cribriform plate, which is formed by the ethmoidal bone. And these, of course, support the frontal lobes themselves. And we have looked at the detailed anatomy of these structures when we talked about the gyri and the sulci. So we have got the gyrus rectus over here, and the medial orbitofrontal gyrus, and then the lateral orbitofrontal gyrus with the rhinal sulcus or the olfactory sulcus over there, and the olfactory bulbs, which we have talked about earlier on, which are kind of the relay center for the olfactory apparatus. And this is just a zoomed view of the same. We've got the medial orbitofrontal gyrus, the gyrus rectus, and the olfactory sulcus, with the olfactory bulbs lying within the depths of the crypts just above over here, the cribriform plates. And this is what the brain will look like. So you've got the olfactory bulbs over here. This is the gyrus rectus, the medial orbitofrontal gyrus, with the olfactory bulbs lying superficially within that sulcus over here. Uh, and just to emphasize that the developing brain is so much in control of the development of the anterior skull base that anything that impairs, that insults the brain, is going to insult the development of the anterior skull base over here. And here is a person, here is a young child, and you can see there are lots of anomalies over here with absence of corpus callosum. You can see there is a very small foramen magnum over there. Even the brainstem looks anomalous with a very thickened thickened midbrain over here, and a very large encephalocele in the midline in the expected position of the cribriform plate, which is defective, herniating into the nose. So the developing brain, which has not developed normally, could not really control the growth of the anterior skull base either. So if you're talking of the midline now, the olfactory bulb, and this is just a couple of points. Again, I would like to remind ourselves, olfaction, a very rudimentary but a very old sensation, and it differs from other sensory systems in that it does not relay into the thalamus directly. It relays into the olfactory bulb, which is considered to be the thalamus of the sense of olfaction. So we have got the olfactory nerves which perforate through the cribriform plate, and they then uh, 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 will relay in the olfactory bulb into a series of nerve cells, which will then project intracranially as olfactory tracts. Uh, and we'll remember that we talked about this before, that for the numerous olfactory receptor cells, there are only fewer and fewer olfactory bulb cells, and these are responsible for specific patterning and recognition of a peculiar smell that our brain will interpret. But not only that, the reduced number of cells within the olfactory bulb reduced our appreciation and diversity of the signal, and hence in humans, certainly in Homo sapiens, the olfactory bulb reduced number of cells is responsible for lesser degree of perception of olfaction as compared to other animals and birds. Uh, so here we have got what a normal olfactory bulb looks like in underneath the gyrus rectus, and here just behind that you can see a tiny dot over here, which are the olfactory striae. So this is the olfactory bulb, and further on they will project posteriorly as the olfactory striae. And this is the person who does not have the olfactory bulbs, and you can see that the sulcus is also absent, absence of sulcus and absence of the olfactory bulbs in this patient with Kalman syndrome. And these two pathological cases here with traumatic contusions involving the anterior skull base, certainly involving the gyrus rectus and the medial orbitofrontal gyrus. And this is someone with with a midline olfactory meningioma. Uh, Further going posteriorly from the olfactory bulbs, we get the olfactory striae, the lateral and the medial striae, the medial relaying in the septal region around the septum pellucidum, and the lateral relaying in the medial temporal lobe gyri. And we have talked about this previously, so I'm not going to spend too much time upon this, but this is just to show you the medial olfactory stria in this person. Uh, So that was just about the midline, if you like, of what the anterior skull base looks like. So now we will concentrate on the lateral aspects, i.e. the orbits, and then we will end with discussing about the paranasal sinuses and the nasal passage. Now, remember, this is just an overview, and I'm trying to concentrate on the relevance of these anatomical topics of discussion with the anterior skull base itself. Otherwise, each of these topics is going to be a separate point of discussion, and in-depth discussion of the individual topics is not possible. So I'll try and keep the relevance to the anterior skull base in whilst discussing the anatomy of the structures. So let's look at the orbits. Okay, so the orbits, pyramidal shape. So orbit is basically the bone which houses the globe and all the supporting structures. So pyramidal shape, you've got the base of the pyramid here at the orbital rim, and then the apex, which is right at the back, which is very close to the brain substance itself. Some peculiarities of the orbit: the medial walls are parallel, the lateral walls are kind of divergent, that enhances or peripheral field of vision. Also, the rim is very thick, so is the orbital apex, very thick, and that is really to protect the eye here and also to protect the brain at the back end. But this comes as at a cost, and the cost is the walls of the orbit, particularly the medial wall and the floor, is not as thick. The lateral wall is quite thick, as is the rim, but the medial wall and the inferior wall are the ones which are thinnest, and usually will take the blunt of the force applied to the front of the face, and will give in thus protect the more vital structures right at the back of the orbit. So I'll try and simplify the discussion by discussing the various structures within the orbit. But let's look at the various walls of the orbit, because these are easily available for inspection. Certainly the rim of the orbit, and it has got very significant pathological correlates associated with that. So we have got the roof of the orbit. Of course, roof is the roof, the medial wall, the floor, and the lateral wall. And as I said, the medial wall and the floor are the ones which are the weakest link, but the lateral wall and the roof are relatively stronger. If you look at the boundaries, of course, just above the roof, we have looked at the brain itself. Medially, we had the cribriform plate with the gyrus rectus. Moving on, we had the medial and the lateral orbitofrontal gyrus. Medially, of course, lies the entire nasal passage with its contents. Inferiorly, we are going to deal with the maxillary sinus, and laterally is, of course, the lateral rim of the orbit. But more posteriorly, the lateral rim of the orbit, here you can see it's related to the parts of the middle cranial fossa which can project anteriorly, but also to the temporal fossa itself. So here we have got some images here. So this is the orbit. We have got the roof, the medial wall, the lateral wall, the floor, and the relationships. You have got the brain above here. We have got the nose and the nasal cavity here, and the maxillary sinuses. That's on the CT scan, and this on the MR scan. So looking at the individual walls, so the medial wall of the orbit, which is one of the weakest portions of the orbit, and it is really lined by ethmoidal bone predominantly, though most anteriorly you get bit of the maxilla which shows up, but otherwise mostly it is lined by the ethmoidal bone, which is a very thin bone. You can see how paper thin it is, and it is called as a lacrimal bone. More posteriorly, as we reach towards the central skull base, it is lined by the body of the sphenoid, and because it is so thin, it can be susceptible to trauma. So this is what a normal bone looks like, and you can see this person who's got a traumatic contusion with emphysema within the front of the orbit, but has also fractured the medial wall of the orbit, because this is, as I said, the part of the orbit which easily gives way. Not only disease can go from orbit into the sinuses, but also from sinuses, disease can spread into the orbit. This is someone who's got ethmoidal sinus disease, and there is a subperiosteal abscess related to that, which is bulging into the orbit. So it is easy for disease to traverse between these compartments. And this is another person here who's got a tumor within the medial wall of the orbit and the ethmoidal sinus with this air fluid level, which is characteristic of an aneurysmal bone cyst. I'm spending a little bit more time on these walls. because they're crucial here to understanding the anatomy of the sinuses as well. Then we come to the floor of the orbit, which is another weak portion, which is formed by the orbital plate of the maxilla. Remember, the maxillary sinuses is here. More posteriorly, we get bits of the zygomatic bone and a bit of the palatine bone, which contribute towards the floor. And here we have got the floor of the orbit, and you can see again another weakness within the link of the orbital rim. You have got the orbital floor over here, and you can see a fracture within the floor of the orbit because of blunt trauma with herniation of tissues, and it's herniation of these tissues which has got quite significant pathological correlates, because through this defect you can get herniation sometimes of the muscles. So this is the inferior rectus muscle. This is where it should be normally contained above the floor of the orbit. Here it's herniated, and this is going to cause uh, uh, abnormal motion or restrict motion of the patient. Sometimes you don't necessarily have to have the inferior rectus. Sometimes you can have fat which can protrude down, and this fat can tether the muscle and impede its movement during ocular motion. Uh, the other important structure along the floor of the orbit is this foramen over here, which is the infraorbital canal, which contains the infraorbital vessels, but crucially the infraorbital nerve, which is a branch of the maxillary nerve. And we have discussed this when we looked at the maxillary nerve, and it is mainly a sensory nerve which supplies sensation to the front of the face, over the maxilla, and along the lower aspect of the eye. But also it can be a conduit of disease. And this patient over here, who's had previous melanoma on the face, and you can see this nerve, which is barely visible on the one side, is quite enlarged on the other side, and is going to transmit, unfortunately, metastatic cells from the front of the face all the way back towards the pterygopalatine fossa and into the trigeminal nerve. So that was the floor, and then the lateral wall on the and the roof. These are the strongest walls. The lateral wall itself is very difficult to break it. Sometimes you can get diastasis along the suture lines, but it's rarely involved in any traumatic injuries. The roof, again, the roof is a fairly strong buttress of bone. But one thing to remember about the roof of the orbit is that you can get pneumatization of the frontal sinus to variable extent, and that can produce disease in the roof of the orbit. And this is a patient. You can see the frontal sinus here encroaching upon the medial aspect of the roof of the orbit, whilst on the other side it would have been pneumatized. This would have been the frontal sinus, but it is diseased, it is opacified. In fact, not only is it opacified, there is a break within the wall of this frontal sinus. This is a mucocele with secondary disruption and encroachment upon the spinal canal. And this person over here, this is the normal orbital roof. You can see they have got a disease within the roof of the orbit, which is hyperostotic. This is metastasis from prostate, and also with some soft tissue swelling associated with a tumor. Having looked at the walls, let's look at the various communications. Three typical ones that we need to understand are the optic canal, the superior orbital fissure, and also the ethmoidal canals. Let's look at the optic canal. And we have looked at this anatomy before, but it's useful to revise that. Optic canal is oriented in a slightly oblique plane to the midline, as opposed to the superior orbital fissure, which is more or less in the parasagittal plane, laterally and inferiorly. Optic canal is in between the sphenoid body over here posteriorly, and here it is on a CT scan, sphenoid body posteriorly, and the anterior clonide process. Along with that, we have got the two, what we call as the struts of the lesser wing of sphenoid. So this is the lesser wing of sphenoid. Here we have got the lesser wing of sphenoid coming in, and the lesser wing of sphenoid is going to go and attach to the sphenoid body by two struts, and in between these struts is the optic canal, and this is what we're seeing. So you'll need a bit of imagination to understand that the struts are going to be above and below this optic canal, which will transmit the optic nerve, but also the ophthalmic artery, and that's the location of the optic canal. The superior orbital fissure is slightly at the inferior level. So here we have the superior orbital fissure, which is lateral and slightly inferior to the optic canal, and it is located between the greater and the lesser wings of the sphenoid sinus. And if I just ask you to concentrate on this slide, the optic canal will transmit the optic nerve, which are going to be here. This patient has got superior orbital fissure syndrome with disease, inflammatory disease within the anterior aspect of the cavernous sinus, which will then extend towards the superior orbital fissure. And you can see how the orientation of the canal is much more oblique as compared to the superior orbital fissure. And this is another patient over here who's got a tumor actually, which is involving the superior orbital fissure. And again, to remind, the optic canal is roundabout in this direction, while the superior orbital fissure leads into the cavernous sinus. The optic canal does not lead into the cavernous sinus, it leads itself into the prechiasmatic region of the suprasellar system. So this is a schwannoma which has extended across the superior orbital fissure, and you can see the wasting over here. And again, just to confirm what we had discussed here, the optic canal on the MR scan, the optic nerve, the optic canal on a CT scan, and the superior orbital fissure lying inferiorly and laterally. This is the optic nerve which has just entered into the intracranial compartment. So we are really at the endocranial opening of the optic nerve, and the superior orbital fissure is round about this level over here, just beneath the clonoid process and beneath what would be the lesser wing of sphenoid. So on a CT scan, this is where you would expect to find the superior orbital fissure. Uh, the other structure we talk about is the inferior orbital fissure, and this is a much smaller foramen which is located along the inferior lateral aspect of the orbital cavity. So again, remember, this is the orbit. We have got the superior orbital fissure here. Medially, it will communicate with the inferior orbital fissure, and the inferior orbital fissure communicates into the orbit and transmit the infraorbital nerve, but also it will communicate laterally. So this is the inferior orbital fissure. Medially over here, it will communicate with the superior orbital fissure. This is the optic canal, superior orbital fissure, inferior orbital fissure. Optic canal over here, superior orbital fissure, inferior orbital fissure. Optic canal, superior orbital fissure, and inferior orbital fissure. And this inferior orbital fissure is peculiar in that not only will it communicate here, as I said, with the orbit, it communicates, sorry, with the orbit, but also communicates here with the pterygopalatine fossa and laterally with the infratemporal fossa, and that allows disease to spread from one compartment to other quite easily. And here we have got a schwannoma within the cavernous sinus region. It has bulged laterally into the temporal lobe, but you can see how it has extended laterally into the into the pterygopalatine fossa over here, and into the infratemporal fossa, which is here, temporal fossa just around here, but also via the superior and inferior orbital fissures is going to get and extend into the orbit. The other foramen, finally, is the communication is the ethmoidal foramina, and these are very small foramina. We do pick them up on CT scan, and just to show you where the location is, so this is the orbit, these are the nasal passages over here, and these are the ethmoidal air cells located along the medial wall of the orbit. And the ethmoidal foramina are these very small channels over here, and they transmit branches of the ethmoidal arteries, and these ethmoidal arteries themselves are branches of the ophthalmic artery. So the ophthalmic artery will send small branches into the ethmoidal labyrinth, which are called as the anterior and the posterior ethmoidal arteries, and they will supply the ethmoidal air cells, some of the nasal mucosa over there, but also they will send some of the branches which will penetrate and supply the head as well, and the midline forks. And this is what they are seen as on a CT scan. So the globe is going to be here, the ophthalmic artery is going to be behind the globe, and the medial branches, the ethmoidal branches, will go through these ethmoidal canals, supply the ethmoid, but will also penetrate through and through and supply the midline forks and the adjacent meninges. So these are the ethmoidal canals and the ethmoidal arteries. Let's move on to the contents of the of the globe. So we have got the of the orbit. So we've got the globe, of course, the extraocular muscles, the retrobulbar fat, the various nerves, vessels, and finally the neurolacrimal apparatus. So let's look at these structures over here. Okay, so we've got a globe. So the globe is uh, uh, imaged very well with ultrasound, and it's not really the topic for discussion here today. It itself will be a special topic for discussion. Imaging in terms of MR and CT has very limited added value to it, certainly in day-to-day clinical practice. Of course, you can do high resolution MR imaging of the globe and pick up some subtleties, especially along the posterior wall around the retina. But by and large, for day-to-day practice, ultrasound and clinical examination tends to be far better in evaluating the globe. You can see, of course, certain changes within the globe, and there are certain features that are worth mentioning. In that, we have got the high signal that you see on T2-weighted sequences within the anterior aqueous chamber and the posterior vitreous humor with the lens in between. The sclera is very well outlined as a dark structure, and when we give contrast, we see a faint but nice rim of enhancement of the choroid, which is a very vascular structure, and this is very useful to pick up diseases which affect the choroid and the retina. For example, in this patient who's got abnormal enhancement which extends outside the retina into the scleral episcleral space, which is basically an inflammation called as episcleritis. But much more important is the visualization of the optic nerve, and the optic nerve, as we discussed earlier on, is direct continuation of the of the brain, and it this nerve along with its meninges can be seen quite well on an MR scan, and you can see the signal of the nerve is very much dark on T2, and that is because it is nothing but white matter that arises from the brain. And then we have got a small sleeve of CSF that surrounds the nerve, which is the pia with the contained CSF space within it. A little bit of undulation is allowed within the optic nerve, as opposed to this patient where you have got much more tortuosity within the optic nerve. And not only that, this area over here is the optic nerve head, which where the optic nerve attaches itself to the back of the globe. And this patient over here, you can see there is actually indentation on the back of the globe, a patient who has idiopathic intracranial hypertension. So we can see that the CSF, the nerve is ectatic, but there is also prominence of CSF space surrounding it, which is basically the pia and the arachnoid, which have enlarged to accommodate more of the CSF space. The dura of the anterior skull base does not extend along the optic nerve. It will eventually fuse with the periorbita. So there is no dura, of course, covering the optic nerve. Uh, and the optic nerve, as we looked earlier on, passes through the optic canal and then to form the optic chiasm. Uh, and as it passes through the optic canal, that's where it is most vulnerable to trauma. Uh, 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 and the fractures involving the optic strut or the sphenoid sinus. It is also vulnerable to compression from aneurysms. Here we have got a patient who has got a aneurysm arising from the internal carotid artery. This is the internal carotid artery on the left side, and this is aneurysmal dilatation on the internal carotid artery, probably the ophthalmic segment of the ICA, which you can see is compressing the prechiasmatic optic nerve just as it is exiting from the optic canal. Uh, of course, optic nerves, because they are prolongation of CNS, are susceptible to inflammatory processes like multiple sclerosis. And this is a normal optic nerve with a normal sheath, and you can see the loss of clarity of this nerve with high signal, with poor definition of the nerve in the patient with multiple sclerosis with optic neuritis. And finally, the intraorbital optic nerve, as you can see here, normally the sheath enhances very minimally. You can barely see the enhancement over here, but a very strong enhancement, very thick enhancement in the patient with intraorbital optic meningioma. And finally, another disease which is peculiar around this area is meningiomas. And here we have got the optic canal with the optic nerve. You can see just about at the most posterior aspect, you can barely see the optic nerve over here. This is the carotid artery. Over here, this is the carotid artery, and surrounding that you can see abnormal tissue, enhancing tissue, which also extends into the orbit via the superior orbital fissure over here, but also into the optic canal. So you have got the optic canal over here. This is abnormal enhancement within the optic canal, but also into the superior orbital fissure, and continuing intracranially in this patient who has got a paraclinoid. This is the anterior clinoid process, a paraclinoid meningioma. The next structure we'll discuss is the, so we have looked at the walls, we have looked at the communications of the orbit. Uh, we have looked at the optic nerve. Let's look at the muscles of the globe. So if you look at the muscles, we have got the extraocular and the intraocular muscles. The intraocular muscles are really, we cannot resolve them on imaging, certainly not on standard imaging. By and large, we'll be able to look at most of these muscles, especially the recti and the oblique muscles. So we know the anatomy of the rectus muscles. You have got a superior, medial, lateral, and the inferior rectus, and then we have got the two oblique muscles, the superior oblique and the inferior oblique. And these muscles really share a very common origin right at the back of the globe, very close to the superior orbital fissure, around a tendon, a tendinous ring called as annulus of Zinn, which is a very small area right within the depths of the orbital apex. And the nerves, when they start off from this area, will then fan out like a cone, like a muscle cone, into the globe anteriorly, and will attach to the globe on the as a tendinous expansion. It's important to realize that the superior rectus and the medial rectus are very closely related to the optic nerve itself, when whilst the inferior rectus and the lateral rectus are a little bit further away from it. So here we have CT is very useful to look at muscles, especially because the fat within the orbit defines the muscles quite elegantly. So the optic nerve that you can see over here, and then the various muscles, the middle, the superior, the medial, the inferior, and the lateral rectus. And you can just about see also the superior oblique muscle over here. Uh, and this is a person who has thyroid disease, and you can see how the inferior rectus but also the medial rectus muscle is enlarged in this patient preferentially. The oblique muscles, they are smaller, much smaller. They are different than the recti. The superior, middle, and the inferior rectus, of course, supplied by the third nerve. The lateral rectus supplied by the sixth nerve. The superior oblique supplied by the fourth nerve. The inferior oblique supplied by the sixth nerve. The superior oblique supplied, as I said, by the fourth nerve. It is called as it hooks on a specific piece of bone called as the trochlea over here, which is located on the medial wall anteriorly within the orbit, and then it changes direction and passes posteriorly behind the equator and changes the way the muscle would normally act downwards and laterally. And this is an MR scan of a patient, and you can see the superior oblique enhancing in that recess on the left side normally, but on the right side you can see the abnormal enhancement and enlargement in this patient with specific myositis of this muscle. And inferior oblique, a little bit difficult to appreciate because it quite often is not in a single plane. It is the only muscle which arises actually anteriorly within the orbit and extends posteriorly behind the equator in its attachment on the globe. You can see the orientation of this muscle in a slightly coronal plane, but also in an oblique plane, and hence it is a little bit difficult to catch it in a single plane. Orbital nerves. So we have got all the muscles which are involved in movements of the globe, but we have also the sensory nerves which control the various aspects of sensation around this area. And finally, we have got the secretomotor fibers of the facial nerve, which will be involved with tear production and secretion. So if you look at the nerves, so these are the important nerves: the third nerve, the fourth nerve, the sixth nerve, and the ophthalmic division of the fifth nerve. Uh, and we know which are the muscles which are controlled by which nerve. Uh, The nerves the nerves are difficult to appreciate on an MR scan. On a high resolution 3 Tesla MR scan, you will see some of the nerves themselves. But what we tend to see is when there is a pathology which affects the nerve to make them enlarged, like for example in this case where there is enlargement of the third nerve. You can and here you can see it has enlarged the third nerve and passing through the superior orbital fissure into the cavernous sinus. So this is the third nerve schwannoma. Or sometimes you can see when the disease within the nerve has resulted in atrophy of the muscle. For example, in this person over here who's got uh, atrophy of the superior oblique muscle as a result of a trauma to the trochlear nerve at the level of brainstem, and you can see the normal superior oblique muscle over here. The fourth nerve is the longest cranial nerve and is most susceptible to trauma because it is also extremely thin. The ophthalmic division of the fifth nerve is really responsible for the most of the sensory control of the periocular region and just the front of the face around the forehead. And it does that by a series of nerve, the frontal nerve, the lacrimal nerve, and the nasociliary branches. It's important to understand these nerves. Again, we don't see them, but they know where they are located. And here you can see that these nerves are located above the superior rectus muscle. And if we understand that, if we pick up a pathology which lies above the superior rectus muscle in this person over here who's got a schwannoma, it's easy to know that this is very likely to be a ophthalmic division schwannoma. The same person over here also has got a schwannoma of the infraorbital nerve and has neurofibromatosis. And this ophthalmic division is responsible for control and transmission of sensation from the front of the face in just above the orbit, and this helps us to connect that with disease. So we have got the frontal nerve, which then bifurcates into the supraorbital and the supratrochlear divisions over here into the subcutaneous area, and this is that different patient with the superior rectus muscle, again also has an F1. This is a superior rectus. Above that is going to be the ophthalmic division, but you can see how it is extending into the subcutaneous area along the divisions, confirming that this is very likely to be a schwannoma of the ophthalmic division. And finally, the sixth cranial nerve, which is also a fairly long nerve, starts within the floor of the fourth ventricle, passes along the petrous apex through a special Dollary canal, through the cavernous sinus, and then entering into the superior orbital fissure and supplying the lateral rectus muscle. Again, a nerve which we can see in the posterior fossa, and we have seen that but very difficult to see within the cavernous sinus and almost impossible to see within the orbit. But we can see the effects of that in this person who had a meningioma operated a while ago along the petrous apex, but has resulted in atrophy of that lateral rectus muscle. Uh, the arterial system. So we looked at the nerves. Let's look at the arterial system of the orbit, and the artery, of course, is the ophthalmic artery, and we have looked at the variations of the origin of the ophthalmic artery when we discussed the arterial system. The ophthalmic artery supplies the central retinal artery, and which is responsible for the visual vision, and any emboli along the central retinal artery is going to give rise to amaurosis fugax. But also it supplies the lacrimal gland, it supplies the muscles of the eye, and it supplies the ethmoid along the medial wall. And we discussed that early on. Through the ethmoidal canal, these arteries will penetrate the medial wall, but also will penetrate not just into the nose, but will penetrate through the cribriform plate and supply the falx. And this is the falcine artery, which you quite often see during angiograms, and is responsible for fistulas at the anterior skull base or along the superior sagittal sinus. This is an MR scan and a CT angiogram just to show you the internal carotid artery and the ophthalmic artery passing through the optic canal and then lying initially lateral and then swings medially to the optic nerve. Uh, uh, this is a case just to show you the importance of understanding the anatomy. This is a patient who has hemorrhage with epilepsy because of this fistula at the anterior skull base. And what we are seeing here are the varices within the brain. These are the venous varices. And just to remind us, these venous varices are because of a fistula, and the fistula is in between branches of the ophthalmic artery. So this is the internal carotid artery angiogram, the ophthalmic artery. These are the uh, arteries leading towards the fistula, and this is the fistula's communication. And these are the intracranial venous varices, and these are the venous varices which we are appreciating on the CT scan and on the MR scan. But the fistula is located at the skull base, and it is in between these ethmoidal branches of the ophthalmic artery. So the ophthalmic artery inside is going to send the ethmoidal branches which are going to traverse the ethmoidal canal, and the fistula is located at the skull base somewhere around here, and then we see the venous varices. So this is the anterior skull base fistula. Uh, and finally, from the circulation point of view, looking at the veins, very richly supplied the orbit. We have got the superior and the inferior ophthalmic venous plexuses. Sometimes you can see them veins as well, but quite often they start off plexuses and they join up together to form the superior and the inferior ophthalmic vein along the roof and along the floor of the orbit, and drain posteriorly towards the cavernous sinus. This drainage is extremely variable in terms of the direction. Sometimes the flow, especially anteriorly, is going to be drained into the facial venous structures and the angular vein, and drain into the jugular venous system. More posteriorly, the inferior ophthalmic vein will drain via the parapharyngeal venous plexus into the retromandibular venous system, and more posteriorly it drains into the cavernous sinus. So the venous drainage is dependent on which system is more dominant than the other. And of course, any pathology in one area is going to get reflected, which we shall just about see over here. So this is again the cavernous sinus. These are the ethmoidal, these are the superior and inferior ophthalmic veins which are communicating with the cavernous sinuses, which drain posteriorly into the petrosal sinuses. And any disease within the cavernous sinuses is going to reflect on these ophthalmic veins. So here we have a person who has got superior, who has got cavernous sinus thrombosis. This is the carotid artery, and you can see the cavernous sinus, which is distended and filled with clot, and the enlarged superior ophthalmic vein, because there is venous congestion and the superior ophthalmic vein cannot drain normally posteriorly. And this is another person who has got a fistula. We have looked at this case before. This is a carotid artery injection. These are multiple small dorsal inferolateral trunk branches which will fistulate into the cavernous sinus, and indirect fistula, and then the fistula manifests itself with proptosis, pulsatile ecchymosis because of enlargement of this superior ophthalmic vein. Uh, Moving on, looking at the other structures within the orbit. So we have got the globe, we have got the nerves, we have got the optic nerve, the arteries and veins. But what we haven't talked about is how are they invested, how are they kept in place. And they are kept in place by various septae and fat, which not only act as a strut around which these structures are placed, but also perform a good cushion to these structures. When we discuss any anatomy of the orbit, when we are describing pathology, the two important things we determine are A is the pathology in the preseptal state. Why, by that we mean whether the septum, this is the orbital septum over here, which is a fascia. Anything superficial to that is going to be within the eyelids. So is the disease within the eyelids, or is it in the post-septal compartment? And the preseptal compartment, for example, over here you can see there is thickening of the preseptal compartment as compared to the other side, but there is also disease within the post-septal compartment. And the post-septal compartment is further divided by the presence of the globe and the muscles. So the muscles, as we said, will form the muscle cone, and the fat over here is called as intraconal fat, and the fat lateral to the muscle cone is called as a lateral conal fat. And this is how you try and describe diseases. So here we have got a patient who has got a lump over here, which is in the post-septal compartment, but medial to the globe, lying within the extraconal medial compartment. So this is how you would describe the anatomy. And here is a person who actually has got not only intraconal disease, but also lateral conal disease in the retrobulbar tissues. And regarding orbit, I think the final thing is to really discuss about the lacrimal apparatus. So the lacrimal apparatus consists of the lacrimal gland, which will produce the tears under the parasympathetic control from the facial nerve along the greater superficial petrosal nerve, which we have looked at in the past. And these glands, they are located on either side of the eyelid, what we call as the uh, uh, palpebral component and the conjunctival component. So there are two components to that gland, and they will secrete some tears which will flow on the surface of the globe and will then get drained medially uh, and on medial aspect. And these are the two canaliculi which are located along the medial aspect of the eyelids. The superior and the inferior canaliculus which join to form the common, and then they form the lacrimal sac, which is present within the medial wall of the orbit. And the lacrimal sac then drains via the nasolacrimal duct into the nose. The lacrimal sac, the lacrimal gland itself is very readily visible. And here you can see just about the lacrimal sac, which is visible in this person over here. There is marked enlargement of this sac bilaterally, and they have got sarcoidosis. Uh, and this is what a normal nasolacrimal duct nasolacrimal sac can be seen along the medial wall of the orbit. And this person over here has got disease with infection of that sac, dacrocystitis, with inflammation spreading on the medial aspect of the nose. And this is another one who has got dacrocystocele, which is basically enlargement of this lacrimal sac. So this is basically the lacrimal apparatus. The glands and the nasolacrimal duct are readily visible, identifiable, but of course the canaliculi are something which are not visible, and they can be cannulated, and you can inject into them, and you can see the punctum, and you can then analyze them based on by doing dacryocystograms. But on MR scan and on CT scans, these are not readily visible. Okay, so that was really a sort of a view through the view of the orbit. Next 15-20 minutes, we'll discuss about the nose and the paranasal sinuses. We have looked at the embryology of the nose and paranasal sinuses. We have seen how the frontal process of the developing brain controlled facial overgrowth, the maxillary process, the mandibular process will give rise to the formation of the nose surrounding the nasal pit. And the paranasal sinuses are really outpouchings from the nose and will aerate the adjacent bones at variable periods of time, almost up to the second decade in life. Okay, so let's look at the nose paranasal sinuses anatomy. And again, this anatomy is in relationship to the anterior skull base itself. So again, it's not going to be an in-depth anatomy of the nose paranasal sinuses, but as I see relevance to the anatomy and the diseases in the area. Okay, we go back again to try and understand the epithelium of the nose. And you'll remember we talked about the epithelium. There are two types of epithelial cells which line the nasal cavity. One is the olfactory one, which is located very high in the nasal vault, which is close to the skull base over here, medially bound by the nasal septum, laterally by the superior rectus, and superiorly by the cribriform plate. So the olfactory epithelium is located high up, and hence when you have to smell something which is less easily detectable, you try and sniff, and that draws in air and takes the molecules, the odorants, to this recess which is located right at the top of the nasal vault, and helps us concentrate these molecules over here to appreciate that sense, that particular odor. And this is the area which will atrophy as we all age, hence explains why the sense of olfaction becomes poor as we age. The other epithelium, of course, is a much more lateral, which covers all the turbinates, which covers the nasal mucosa, and that is the respiratory epithelium, and that is essential for producing mucus, which will moisten the air, which will keep it which is also responsible for forming a very thin coat on the surface of the olfactory epithelium, and is especially important to for proper functioning and proper transmission of the impulses on the surface of the olfactory epithelium. And hence, if you have got sinonasal disease, inflammatory disease, the mucus production is excessive, and any excessive mucus is going to impede transmission of the anions and cations, which will have to uh, uh, embed themselves to generate impulses from the olfactory epithelium. So it's important to realize the slight differences in the epithelial anatomy. So when we look at the nose and the paranasal sinuses, the nose itself is based on a cartilage model, both on the medial wall uh, as well as the lateral wall. And on the surface of this cartilaginous model, you have got mucosa, which is on the surface, which is seen on clinical inspection and on radiology. And we comment on areas of mucosal thickening, so on and so forth. So the nasal septum itself is a fairly uh, uh, straight structure, usually may have a slight deviation onto one on the other side. Superiorly, it is connected to the anterior skull base, and inferiorly it is connected to the uh, palate, whilst posteriorly it is in contact with the sphenoid sinus. As you go more laterally, you've got the more uh, uh, difficult anatomy of the lateral wall of the nose, which has the bony shells, which are called as the turbinates, on which you have got the nasal mucosa, which is folded on itself, and that allows airflow patterns within the nasal passage going towards the nasopharynx and subsequently towards the trachea, but also it allows drainage of various sinuses into the specific areas within the within the nasal passage. And it is important to understand the anatomy of these drainage pathways, which is really the crux of most of the paranasal sinus surgery, the functional endoscopic surgery. The other relevance, of course, is to understand that the nose and the paranasal sinuses are very close to the anterior skull base, and that is the area of discussion today. And the examples that I shall illustrate will be to discuss those topics. So these are the this is the lateral nasal wall, and you can see the bones, which are the turbinates, on which you have got the mucosal areas of thickening, the middle turbinate, the inferior turbinate, and also the superior turbinate. And this allows, as I said, flow of air through the turbinates, which will then get streamlined, and the air gets humidified and moistened, so that dry air does not reach up to the lung. And these folds ensure that there is a very specific pattern of drainage pathway of the sinuses. For example, you have got a frontal sinus here at the front, the sphenoid sinus at the back, and the maxillary and the ethmoidal air cells which drain in the middle. So the nasal passages are lined by the paranasal sinuses. You've got the ethmoidal air cells, the frontal sinuses, the maxillary sinuses, and the sphenoid sinus right at the back. And all of these sinuses will produce mucus, which then once it is secreted, will eventually find its way into the nasal passage. We'll try and see and understand the anatomy of the sinuses, especially understanding the drainage pathway of the sinus, because it is the anomaly of this drainage pathway which contributes towards the disease. And it's anomaly of this drainage pathway which is often corrected by the surgeons in trying to establish or re-establish the drainage pattern. So the maxillary sinuses, and fairly easy to identify, these are the largest of the sinuses, well aerated, situated beneath the orbits, and separated by them via the floor of the orbit. And we have seen this, the infraorbital canal with a contained nerve. The maxillary sinus is present on either side of the nasal passage, and they drain anteriorly and superiorly and medially into the nasal passage. So let's try and understand a little bit more in detail about how that drainage occurs. So that drainage occurs around a very specific area called as the osteomeatal unit. And this is a diagrammatic representation of that. So this is a maxillary sinus, and you can see how it cones into that area called as the maxillary infundibulum, which opens via the ostium of the maxillary sinus into a very special area over here underneath and lateral to the middle turbinate, just lateral to the middle turbinate, which is called as the hiatus semilunaris, into the middle meatus. So this is the middle meatus, this is the hiatus semilunaris, and this is the infundibulum and the ostium of the maxillary sinus. And this is a very crucial area, and you can see the important vital structures located over here. You've got the middle turbinate over here, you've got the shelf of bone, what is called as the uncinate process, and you've got the ethmoidal bone, the ethmoidal bulla as it is called as, and all of these areas can have anomalies, can have abnormalities which can affect the drainage pathway of this sinus. This is a CT scan to show you the same anatomy, the maxillary sinus with the ostium, with the infundibulum. This is the uncinate process on it, and as you can see, the maxillary sinus drains via the hiatus seminaris into the middle meatus. So any diseases along these areas is going to affect the drainage pathway of the sinus. And just to illustrate some of the diseases over here, just to remind again the normal anatomy, the maxillary sinus, the ostium, the infundibulum, got the uncinate process, and the middle turbinate over here. And you can see this maxillary sinus is chronically small in size, and the uncinate process has been lateralized. It's actually touching the medial wall of the orbit over here. It's touching the inferior aspect of the lacrimal bone, and that can lead to retention of secretions and diseases. And this is another person over here. You can see disease within both the maxillary sinuses over here inferiorly because of occlusion of the osteomeatal unit, the recess which extends from the maxillary sinus ostium all the way into the middle turbinate. And chronically occluded sinuses can lead to eventually the sinuses getting smaller and smaller, and you can see these are the uncinate processes. You can barely visualize them over here, and they're getting more and more lateralized. Normally the uncinate process is in direct continuity with the medial wall of the maxillary sinus, whilst here you can see there is a lateral deviation of this uncinate process. And this is the area that the surgeons would like to address by either truncating the uncinate process or partially resecting the middle turbinate, or resection of the anterior ethmoidal air cells to try and aerate and create a functionally relevant opening of the maxillary sinus. Uh, and chronic sinus disease, of course, can cause chronic osteomyelitis. You have got a normal sharp outline of the bone on this side. You can see that the thickened bone. So this is chronic osteomyelitis of the sinus. But much more worse is when the disease from the sinus. This is a patient who has got disease within the maxillary sinus with retained secretions, also ethmoidal air cell disease, but the disease has now spread into the intracranial compartment with the epidural abscess, as you can see, with diffusion restriction. So this is osteomeatal unit with spread of infection into the intracranial compartment. Let's look at the ethmoidal air cells. So the ethmoidal air cells are a little bit more complex in understanding because A, they are numerous, and B, they are very difficult to differentiate amongst themselves because they are so numerous. So again, to understand the anatomy, so this is posterior, this is anterior over here, this is the back end of the nasal septum, this is the cribriform plate, so the intracranial compartment is going to be here, and on either side of the cribriform plate inferiorly are what we call as the ethmoidal labyrinth, and these are labyrinthine cells, as in they lead from one to the other. So these are there we go. This is the cribriform plate, and this is a septum pellucidum, not septum pellucidum. This is a nasal septum, and the ethmoidal labyrinth on either side. And again here, this is the cribriform plate over here, cribriform plate with the crista galli, which is what we are seeing here: crista galli, cribriform plate, and the ethmoidal air cells between the orbits over here, the lamina papyracea, which separates the ethmoidal air cells from the orbit, and these are the ethmoidal air cells, and medially they are bound by the turbinates. So these are the ethmoidal air cells, and they are classified as anterior and posterior ethmoidal air cells based on how the attachment of the middle turbinate is. But these are the extensive ethmoidal air cells, and they all drain into the middle turbinate. Uh, uh, An important thing to identify when we're looking of the ethmoid is the roof of the ethmoid, and the roof of the ethmoid is crucial because above the roof of the ethmoid is the anterior aspect of the base of the frontal lobe. And we have looked at this before. In the midline we have got the crista galli. On the both lateral aspect are the cribriform plates, and just lateral to the cribriform plate are these areas which cover the ethmoidal labyrinth, which are called as a fovea ethmoidalis. And it's very crucial to look at this anatomy in detail, especially prior to FESS surgery, or in someone on whom a transsphenoidal surgery is been contemplated to access the pituitary area. by the sphenoid sinus. So I'm just going to spend a little bit more time to explain this anatomy over here. And you can see this is the anterior skull base over here with the crista gala in the midline, and the red arrow points to the depth of this, what we call as the olfactory recess. And you can see the olfactory recess is quite deep over here, whilst it is very shallow over here. And this is the olfactory recess on either side of the crista galli. This is the cribriform plate over here. This is the fovea ethmodalis, and it is this height that we are trying to understand. If it is a very deep height as opposed to a very shallow height, and you can see how deep this height is. And any underappreciation of the anatomy of this area is going to result in hazards during procedures. And this person who had a FISS surgery, you can see they have had a breach of the cribriform plate with subsequent pneumocephalus and potential risk of infection into the intracranial compartment. And this is a congenital defect over here, and you can see the cribriform plate itself is very, very thin, very difficult to identify, but they have got a soft tissue opacification in a person who had intercurrent infections, meningitis, and you can see that there is a soft tissue just medial to the superior turbinate over here, and you can see how the gyrus rectus is herniating in this patient with a defect of the superior aspect of the cribriform plate. So the bone itself is a deterrent to spread of disease, but it can be permeated by infection, and we have seen that. But also tumor, it can breach the anterior skull base. And when we are looking at tumors of the nose or the paranasal sinuses, extremely crucial to give contrast to appreciate any subtleties in enhancement. This is involvement of the dura of the anterior skull base. This is the same person who has got now high signal within the frontal lobe, consistent with spread of tumor intracranially, and you can see there is also spread going into the orbit. So the ethmoidal carcinoma has now spread into the brain, has also spread into the orbit by breach of the lamina papyracea. Different individuals here. Medial wall of the ethmoid, this is the ethmoid air cell over here. The medial wall is the most susceptible to diseases, and here you have got a person who has got a fibrous dysplasia which has started to bulge into the orbit. Got a patient who has got infection within the ethmoidal air cells with a subperiosteal abscess extending into the orbit. And we have looked a similar example before with a fracture of the medial wall of the orbit with herniation of the fat into it. So the medial wall of the orbit, which is basically formed by the ethmoidal labyrinth, is one of the most delicate part of the orbit. The frontal sinus is variable in terms of the degree of pneumatization. It is extremely variable in terms of how it drains, not where it drains, but how it drains, because it is influenced by the anterior ethmoidal air cells. So the frontal sinus drains via a small channel along its inferior aspect into the middle meatus, but this recess over here is closely guarded by anterior ethmoidal air cells, and the diseases within these cells will cause pathology and obstruction to this sinus drainage pathway. And these areas are best ascertained either on a coronal or on a parasagittal plane. So here we have got a frontal sinus and this typical crenated appearance, septated appearance within the sinus. The frontal sinus is in the coronal view, and the frontal sinus is here you can see along the inferior aspect draining into the middle meatus on either side of the middle turbinate. And you can see how closely they are related to these ethmoidal air cells. So any diseases within the ethmoidal air cells is going to influence and cause obstruction of the frontal sinus drainage pathway. And this is just to show you another example here. This is the frontal sinus. This is an anterior ethmoidal air cell, and this is the drainage pathway. And this is again the complex drainage pathway of the frontal sinus, which can be influenced by the anterior ethmoidal air cells, but also by the bulla ethmoidalis, which is located here along the posterior aspect of the frontal sinus recess. Uh, uh, some diseases to exemplify the anatomy. The frontal sinus grows itself into the roof of the orbit, especially on the medial aspect. And we have looked at another example before. if there is any obstruction to the drainage pathway of the frontal sinus, it is going to cause retention of secretions and expansion of the sinus with the mucocele with dehiscence, which will then project into the orbit. And this is another person over here who has in fact developed not just the mucocele, but the mucocele has got infected and is now a pyocele. Infection can of course spread from the frontal sinus into the adjacent brain with abscesses into the brain substance, but also can result in superior sagittal sinus thrombosis. Remember, the superior sagittal sinus is in the midline, and spread of infection can then rapidly extend along the superior sagittal sinus. So frontal sinusitis, very crucial to evaluate, especially the posterior wall, where it is in close contact with the adjacent frontal bone, and the inferolateral wall, where it is in close contact with the orbit. The final bit in the discussions of anatomy is the sphenoid sinus. The sphenoid sinus, the most difficult sinus to evaluate clinically because it is so deep and most posterior. It forms actually part of the central skull base. So it is not really anterior skull base, but because we are also discussing on the sinuses, I thought it would be useful to finish off the discussion of sinuses by talking a little bit on the sphenoid sinus. Sphenoid sinus is caused by pneumatization of the sphenoid bone, the body of the sphenoid. But not only that, the sphenoid sinus can also extend into the various recesses of the sphenoid sinus. It is located right at the posterior aspect of the ethmoidal air cells, and the ethmoidal air cells can sometimes actually protrude into the sphenoid sinus, and it drains via the sphenoethmoidal recess into the superior turbinate. And here you can see the sphenoid sinus draining into the sphenoethmoidal recess. Uh, the degree of pneumatization can be very varied and between the two halves, and you can see here that the intersphenoidal septum is deviated towards the left side, giving rise to a slightly smaller left-sided sinus and slightly bigger right-sided sinus. And it's important to understand this degree of pneumatization, and it's important to discuss it with the treating surgeon, especially someone who's going to access the pituitary area or the area around the clivus. And this is just to illustrate the degrees of differences in pneumatization. Here you have got a patient who's got limited pneumatization just in the anterior aspect of the sphenoid body. Here is pneumatization which extends up to the anterior margin of the sella, whilst here the pneumatization has extended all the way up to the dorsum. This obviously is much more easily accessible to surgery, whilst here this will involve drilling into the bone to access the relevant areas. So it's important to discuss the degree of pneumatization, whether it is choanal, whether it's pre-sellar or sellar pattern of pneumatization. Neurovascular relations, we have looked at this before. The carotid artery can sometimes actually bulge into the sinus, and this is a person who has got a sphenoid sinus disease with obstruction of the sphenoethmoidal recess, and it's very important to identify this protrusion into the sinus to avoid any inadvertent trauma to the petrous and the precavernous portion of the internal carotid artery. Similarly, the optic canal can also protrude into the sphenoid sinus. This is a patient who has dehiscence of the coverings of the optic canal. So this is the optic canal struts, and there is a pneumatization of the of that strut, and the optic canal is actually protruding into it, and hence it's important to identify that and mention it in the report. And just finally, we will talk about this in detail when we discuss the middle cranial fossa. These are the sphenoid sinuses, and within the walls of the sphenoid sinuses, we have got the foramina rotundum, which will contain the maxillary nerves as they traverse from the cavernous sinus over here anteriorly into towards the pterygopalatine fossa, which is going to be round about here at a slightly inferior level. But just to illustrate the disease, sometimes you can have disease, inflammatory pattern of disease surrounding these nerves, and that can cause referred pain, especially along the anterior cheek, and hence can explain why sometimes when we have sinusitis, we can get tenderness on the anterior aspect of the cheek. The other aspects of the sphenoid sinus, very important to understand, are that they are related to the cavernous sinuses, and we have discussed the anatomy of the cavernous sinuses. Here is a person with the disease within the sphenoid sinus, destroying the bone, resulting in cavernous sinus thrombosis over here on a post-contrast CT scan, and this is on an MR scan where there is a large thrombus occluding the cavernous sinus. I think that's all I had to discuss this week about the sinuses. So we have looked at the orbit and the sinuses and the nasal passages. You'll realize I've kind of tried to stay close to the anterior skull base in terms of my discussions of the anatomy and the relevant diseases. There is of course much more detailed anatomy to discuss, but I don't think that would be relevant at this point. So next week we'll discuss on the middle cranial fossa. So we'll take any questions if you have any. Thank you.